Hi everyone, my name is Owen Dooley Phillips. This presentation focuses on compassion fatigue and burnout in counseling practice, and why this topic matters for therapist well-being, ethical care, and sustainable practice. I'll define compassion fatigue and relate constructs like secondary traumatic stress and vicarious trauma, and review key models, including Figley's compassion stress and fatigue model and Stam's Pro QOL framework. And I will summarize what the research suggests about risk factors, protective factors, and practical strategies that counselors can actually use. So, overview. Here's the roadmap. I'll start by explaining what compassion fatigue is and why it matters for counselors. Then I'll clarify the differences between burnout, secondary traumatic stress, and vicarious trauma, because these terms often get mixed together in both practice and research. Um, After that, I'll highlight key theoretical models and research findings across helping professions, including psychotherapists and trauma therapists. And finally, I'll cover risk factors, warning signs, protective factors like supervision and self compassion, and end with ethical and cultural implications, plus discussion questions for the forum. Learning objectives. By the end of this presentation, you should be able to define compassion fatigue and related constructs, explain the major models used to conceptualize compassion fatigue, summarize recent research about therapy well-being, and identify risk and protective factors, and apply realistic prevention and resilience strategies within counseling practice. So, background and context. Helping professionals regularly encounter trauma, grief and loss, crisis, and intense emotional distress. So, in counseling, empathic engagement is essential. We're not doing mechanical tasks. We're constantly attuning, holding emotion, and staying present. And of course, over time, that repeated exposure to suffering can create emotional strain. Figley's early work describes this as a cost of caring, not because empathy is bad, but because sustained empathic engagement, especially in trauma exposed work, requires recovery and support to remain sustainable. Uh, Systematic review research also supports that these demands show up across a range of helping professions. So, why compassion fatigue matters? This matters because compassion fatigue isn't just having a hard week. Counselors may hear detailed trauma narratives, witness emotional suffering, and carry the emotional weight of clients' experiences session after session. So, over time, this emotional labor can influence psychological well being and eventually impact professional functioning. The reason instructors and regulators care about this topic is that therapist well being can influence clinical presence, responsiveness, and the therapeutic alliance. So, awareness and prevention aren't just optional add ons, they are part of ethical, competent, and sustainable counseling. Literature review. The compassion fatigue literature pulls from several research streams: trauma theory, secondary traumatic stress, burnout research, and professional quality of life models. One consistent theme is that compassion fatigue is multidimensional, not a single symptom and not caused by one single factor. Another theme is overlap. Compassion fatigue is often discussed alongside burnout and secondary traumatic stress, which can make comparing studies tricky unless definitions are clear. That's why models like Figley's and Stam's are useful. They give language and structure for understanding how empathy, trauma exposure, work stress, and protective factors interact over time. Defining compassion fatigue. So, compassion fatigue is often described as, quote unquote, the cost of caring for people experiencing emotional pain. In practical terms, it can include emotional exhaustion, reduced capacity for empathy, and stress related to exposures to others' trauma. It also commonly conceptualized as overlapping with secondary traumatic stress and burnout, which helps explain why people can both feel trauma related strain and workplace exhaustion at the same time. So, what I want to emphasize here is that compassion fatigue is not simply just being too sensitive, it's an occupational risk that can emerge when exposure and emotional demand outpace recovery, support, and effective coping strategies. So burnout versus fatigue. So these are the two main components of this presentation. So it's important to distinguish them. So even though they are related, burnout and compassion fatigue, they're not identical. Burnout was classically measured by Malashk and Jackson as a response to chronic workplace stress, often involving exhaustion, depersonalization, or cynicism, and reduced sense of efficacy. Burnout tends to develop gradually and is strongly influenced by workload, organizational culture, role overload, and lack of resources. On the other hand, compassion fatigue is more directly tied to exposure to other suffering, especially trauma narratives, and the emotional load of empathic engagement. A useful way to say it is burnout is more system stress and workplace depletion, while compassion fatigue is more trauma exposure and empathetic strain. Although in real life they often interact, literature by Bugera also discusses the relation between compassion fatigue and burnout in healthcare contexts, which supports the idea that these constructs can overlap but still have different roots. Secondary traumatic stress. So, secondary traumatic stress refers to psychological distress that results from indirect exposure to trauma. So, for example, hearing repeated detailed trauma narratives, working closely with traumatic survivors, or engaging in vivid trauma processing with clients. Symptoms can include intrusive thoughts, emotional distress, and avoidance. And this is not because the therapist experienced the trauma directly, but because of sustained empathic exposure. Conceptually, this helps explain why counselors can experience trauma like stress reactions even when they are functioning well professionally. Hansel and Saltzman's literature in traumatology highlights how secondary traumatic stress and burnout can coexist and relate to broader well being factors in helping work. Vicarious trauma. So vicarious trauma is slightly different. Research from McCann and Perlman, they describe vicarious trauma as lasting cognitive changes that can occur in therapists as a result of exposure to clients' traumatic experiences. The key distinction is that STS focuses more on symptoms like distress reactions, while vicarious trauma focuses on changes in worldview and belief systems. So, for example, therapists may notice shifts in beliefs about safety, trust, control, identity, or meaning over time. This matters clinically because it can subtly shape how therapists interpret client stories or engage in relationships and feel emotionally safe in their work and personal lives. So here we have Figley's compassion stress and compassion fatigue model, created in 1995. The term itself was actually originally coined in 1992. So Figley's model is helpful because it shows compassion fatigue as a process. Repeated exposure to suffering activates an empathic response, and that empathic engagement can generate compassionate stress. If that stress accumulates as residual compassion stress and recovery resources aren't sufficient, compassion fatigue can develop. So, what's important here is that the model includes the idea of accumulation, not one bad session, but that repeated exposure over time, as we discussed. And it highlights why supports like supervision, recovery, and boundaries can interrupt the pathway for empathic engagement to fatigue. Compassion fatigue, an integrative model framework. So this slide pulls together the pieces. Compassion fatigue can be understood as the interaction of three forces: empathic engagement with suffering, indirect trauma-related strain, and chronic occupational stress. These processes influence therapists' professional quality of life, which means that prevention isn't just, quote unquote, do self care. It includes emotional regulation skills, realistic caseload structure, and supportive supervision. And on top of that, organizational factors like workload and culture. A helpful takeaway is compassion fatigue is rarely caused by just one thing. It's usually a combination of exposure, emotional loads, stress context, and resources. So, measuring compassion fatigue, professional quality of life, ProQOL model. So, STAM's professional quality of life model breaks professional well being into three dimensions: compassion satisfaction, burnout, and STS. The ProQOL model is useful because it measures both positive and negative aspects of helping work, meaning the same work can create strain and meaning at the same time. This is why the ProQOL gets used so widely in research and practice, because it gives therapists a structured way to self-reflect and identify whether their risk is trending more toward burnout, STS, or whether compassion satisfaction is buffering them. Compassion satisfaction. So this is more on the positive side of things. So compassion satisfaction refers to positive feelings derived from helping others, a sense of purpose, meaning, a perceived effectiveness as well. In the ProQOL framework, compassion satisfaction is associated with lower burnout and lower compassion fatigue risk. And it matters because it's one of the reasons people can stay in the field even when the work is heavy. So, in practice, compassion satisfaction can look like feeling grounded after a meaningful session, noticing a client's progress, or feeling aligned with your values as a counselor. So, even when the work includes trauma and pain, um, it's still sustainable if we're able to get some compassion satisfaction. Compassion fatigue in psychotherapists. So, research on psychotherapists show something important. Therapists can experience compassion fatigue and burnout and still report compassion satisfaction. Levadier, his work on clinicians' empathy and professional quality of life, it highlights how therapists' well being is connected to professional functioning, and it reinforces why training, supervision, and a supportive work environment matters. The broader point here is therapist well-being isn't separate from clinical skill. It's part of being effective and sustainable as a professional. So, prevalence in trauma therapists. So, trauma therapists may be at higher risk because of their caseloads. They often involve intense trauma narratives and high emotional labor, and then that sustained exposure to it. Velasco, his research examined secondary trauma, compassion fatigue, and burnout among trauma therapists. And he found meaningful levels of these outcomes while also noting that many trauma therapists still report compassion satisfaction. So that combination, risk plus meaning, it really captures what many clinicians describe The work matters deeply, but it also requires intentional support structures to remain sustainable. So it really raises an interesting point that um, just because you are involved in higher risk work, emotionally exhausting work, um, you are still capable of sustaining healthy practice as well. Empathy versus compassion. So, research by Singer and Klemecki, they make a useful distinction here. So, empathy is sharing another person's emotional experience, while compassion involves concern plus motivation to help. Their research suggests that high empathy without adequate regulation can tip into empathic distress, which can contribute to exhaustion and withdrawal. So, clinically, this supports the idea that preventing compassion fatigue isn't about caring less. It's about building skills that allow therapists to stay emotionally present while maintaining self other boundaries and effective emotional regulation. So, factors. Uh, they generally fall into three different categories. So, individual, professional, and organizational categories. So, individual factors, they include high empathy, personal trauma history, and difficulties with emotional regulation. Looking at the professional factors, they typically include high trauma caseloads and emotional labor, high variation of it, raises risk. Um, and then on organizational level, so organizational factors include heavy workload and limited supervision. These are the key contributors. Um, One important finding by Andrzejowska and Alamova's work is that self-criticism can be a strong predictor of compassion fatigue, which shifts the conversation from "you were too empathic" to "what's your inner dialogue under stress." And more recent longitudinal work on emotional regulation in mental health professionals, it highlights emotional regulation as a meaningful protective mechanism, not just one of these wellness buzzwords. So, impact on clinicians. So, we already discussed a little bit about this, but compassion fatigue can lead to emotional exhaustion, reduced job satisfaction, and professional disengagement. It can show up as feeling depleted at the end of the day, feeling less emotionally available, or noticing your patience and curiosity shrinking. Research by Newell and McNeil's review emphasizes that burnout, STS, vicarious trauma, and compassion fatigue are interconnected constructs, and that when unchecked, strain can affect professional functioning over time. The key point is not that therapists become bad therapists, but that even competent clinicians can become depleted if exposure and stress exceed recovery and support. Some other interesting research notes that it's not just the helper professions that can get affected by compassion fatigue. Compassion fatigue can affect people who have many children, take care of people with disabilities in a family context, and then also dealing with parents or loved ones that suffer things like dementia and Alzheimer's, because often in these conditions, you are potentially forced to give your all to these people with not necessarily getting any sort of reciprocation in terms of empathy or care. So, without realizing it, subconsciously, We have sometimes these expected roles of us, whether it's mothers, daughters, parents, that we are supposed to do this role without any individuation. Taking time to go on a trip or engage in hobbies and interests. Um, Often this can happen where people who take on these roles dedicate it fully to the cause um, at the cost of themselves. So, as Figley termed it, the cost of caring. So, it's important to note that it doesn't just impact clinicians or helper roles like social workers, healthcare workers like nurses, but it also impacts parents and caregivers. So it's important to remember that when we talk about the impact of compassion fatigue. And of course, you have individuals that, could be social workers, mothers, taking care of parents with Alzheimer's. So it can really compound from multiple avenues, compassion fatigue. Impact on client care. So this matters because therapist well-being affects responsiveness. When clinicians are depleted, it can impact the therapeutic alliance, clinical decision-making, and then overall quality of care. Lavadier, his research links professional quality of life with core aspects of professional functioning, which supports the broader idea that therapist well-being and client care are connected. In practical terms, compassion fatigue may show up as reduced emotional presence, less flexibility, or going into autopilot in sessions. This is not a character flaw, but it's a signal to your body that it needs support and it needs recovery. So, understanding what your own nervous system needs is also a complementary thing involved there as well. Protective factors. Protective strategies include supervision and peer support, self compassion, reflective practice, and emotional regulation skills. Supervision matters because it gives a place to process emotional residue from sessions. Not just case conceptualization, but the therapist's internal experience. Self compassion and reduced self criticism show up in the research as protective factors, which again emphasize that what therapists say to themselves under stress can shape burnout and fatigue trajectories. Research by Newell and McNeil also highlight preventative methods like supervision, workload management, and self care that are grounded in the realities of clinical practice. So it's important to note when you're feeling symptoms potentially of compassion fatigue or burnout that there are things you can do to prevent it from compounding and getting worse. And there are things you can do to sustain yourself within the work. It was found through research that burnout, particularly, actually led to people completely changing their field altogether, changing their profession. Whereas, on the other hand, compassion fatigue, it was found that more people just left that organization but stayed within the same field. So that's also an interesting component. Ethical responsibilities. So, ethically, therapists have an obligation to maintain competence and self awareness, monitor well being and potential impairment, and seek supervision and support when needed. In Ontario, CRPO's professional practice standards emphasize ongoing self monitoring and competence, and note that practicing while impaired is a serious professional issue. A key point I want to stress is that prevention is both individual and organizational. It's not ethical to place the full burden on individual clinicians if systems create unsustainable workloads and limited supports, which is why organizational responsibility shows up repeatedly in the research literature. Cultural considerations. Cultural factors can shape how burnout and emotional distress are perceived, whether professionals feel comfortable seeking help, and whether stigma exists admitting strain. Workplace expectations and systemic inequities can also influence risk. So, for example, some settings normalize overwork, discourage vulnerability, or treat self care as optional. So the intersectionality matters too. Clinicians' identities and lived experiences can shape their exposure to stressors and the supports available to them. So culturally, responsive prevention means creating supports that are inclusive, accessible, and sensitive to different norms around emotional expression and help seeking. So, in conclusions, to wrap this up, um, compassion fatigue is a significant risk in helping professions, especially where trauma exposure and emotional labor are high. The research suggests that compassion fatigue overlaps with burnout, secondary traumatic stress, but can be understood as a multidimensional process shaped by exposure, emotional overload, workplace stress, and available supports. Protective factors like compassion satisfaction, supervision, self compassion, emotional regulation, and supportive work environments reduce risks. And ultimately, supporting therapist well being improves not only clinician sustainability, but also client care and ethical practice as well. So, as we all enter the field of psychotherapy, I think it's important to note that compassion fatigue can affect us all and burnout can affect us all, and to be aware of how secondary traumatic stress and vicarious trauma can potentially affect you. Having those self awareness and being able to make those distinctions allows us to understand what's going on and allows us to understand what potentially is happening within our body, and understanding that if we are working with clients with high trauma, or clients who can create that emotional exhaustion, to use those protective factors, as we already have supervision, but to carry on getting supervised beyond practicum, to continue to use reflective practice, whether that's journaling, whether that's meditation, whether that's simply just doing some physical exercise like going for a walk. These things can become extremely important. And also to be aware going forward beyond practicum, as you enter occupations, what is that occupational structure like? Does it support employee well being? Does it support and understand the psychoeducational risk for clinicians and how they can be impacted by trauma? Does your workplace take time to dedicate to employees to have some chances to take care of themselves, whether that's simply things like holidays or things like sick pay and time off? These are important considerations and factors when entering an occupation in a workplace. So, discussion questions. So, these are a few of my discussion questions. How can counselors maintain empathy while protecting their own well being? What role should organizations play in preventing compassion fatigue? How might cultural factors influence experiences of burnout and compassion fatigue? And how can workplaces support therapist well being and resilience? So, I really appreciate you guys taking the time to take a look through my presentation and making it all the way to the end here. I really appreciate that you took your time to listen to it, and I look forward to hearing on the forums your perspectives and engaging with you guys. Take care. Have a great day. Goodbye.